Welcome to this explainer. Okay, let's dive straight into a seriously high-yield endocrinology topic and really bridge the gap between foundational physiology and what you actually do in clinical practice. If you're a medical student, a resident, or an attending, you already know the thyroid gland is tiny, but man, it punches way above its weight class. Today, we're going to unpack exactly how it works, what happens when the whole system fails, and how you can absolutely master the clinical scenarios you're going to see on the wards and on your board exams. To structure our clinical rounds today, we're covering 5 key areas. 1. Physiology of the HPT Axis. 2. Clinical presentation, focusing on Sunita's case. 3. The diagnostic algorithm and its pitfalls. 4. Systemic complications and emergencies. And 5. Board prep and clinical pearls. Let's kick things off with Section 1, Physiology of the HPT Axis. So think of the Hypothalamic-Pituitary-Thyroid axis as your body's ultimate metabolic command center. This negative feedback loop starts when circulating thyroid hormones, mainly T4 and T3, start to drop. That drop triggers the hypothalamus to release TRH. TRH then knocks on the door of the anterior pituitary, basically telling it to release TSH. Now, TSH is the main driver here. It heads straight down to the thyroid gland to push iodine uptake and ramp up the synthesis of T4 and T3. And once those hormone levels rise back up, they feed back to the brain to shut the whole system off. It's just a brilliantly elegant, highly sensitive thermostat. Now, taking it down to the cellular level, we find the mechanism that explains practically every symptom of hypothyroidism. The thyroid gland produces mostly T4, right? But peripheral deiodinases actually have to convert that T4 into active T3. Once it's inside the cell, T3 gets to work altering gene transcription. It ramps up the sodium-potassium ATPase pump, increases your mitochondrial count, and drives up oxygen consumption. The big takeaway here is that active T3 is literally the cellular engine. So when thyroid hormones fall, every single cell's metabolic rate drops with it. Moving right along to Section 2, Clinical Presentation, Sunita's case. Let's bring this to the bedside. Meet our patient, Sunita. She's a 38-year-old female presenting with some very classic complaints. She's frustrated by a 6-kilogram weight gain over the last 8 months, and this is despite absolutely zero changes to her diet. She's also experiencing severe cold intolerance, persistent fatigue, constipation, dry skin, and heavy, irregular menses. When her laboratory panel comes back, it completely confirms our clinical suspicion. She has a sky-high TSH of 38.6, a severely low free T4 of 0.4, and she's positive for anti-TPO antibodies. Plus, her hemoglobin is running a bit low at 10.8. All right, Section 3, Diagnostic Algorithm and Pitfalls. Diagnosing hypothyroidism might seem straightforward, but clinical practice is full of traps. Before we finalize Sunita's diagnosis and jump into management, I want you to use some active recall here. What is the single most sensitive screening test to start with? Keep in mind, symptoms like fatigue, weight gain, and cold intolerance are incredibly common and super nonspecific. The key takeaway here comes straight from the American Thyroid Association guidelines. Because hypothyroid symptoms overlap with so many other conditions, like depression, anemia, or honestly just high stress, you can never diagnose this on symptoms alone. Always start with TSH as your absolute best initial screening test, and definitely never treat nonspecific symptoms with empirical levothyroxine unless you have biochemical confirmation. You really want to stick strictly to this 4-step golden rule algorithm. Step 1, screen with TSH. Step 2, if that TSH is abnormal, you confirm it and grade the severity with a free T4. Step 3, identify the underlying cause by ordering anti-TPO antibodies. In Sunita's case, this confirmed Hashimoto's. And Step 4, treat and monitor. You start a weight-based levothyroxine dose and then recheck the TSH in about 6 to 8 weeks. By following this exact path, we confidently confirmed Sunita's overt primary hypothyroidism and got her managed correctly. To interpret these labs like a pro, you have to master this specific matrix. It is absolute gold for your board exams. The golden rule is this: in primary disease, the broken thyroid gland causes T4 to drop, which then drives TSH way up via negative feedback. But consider central or secondary disease. If the pituitary gland fails, it simply can't produce TSH. So that central pituitary failure leaves the TSH inappropriately normal or even low, despite a low free T4. And of course, don't forget sick euthyroid syndrome, where a really severe systemic illness causes a transiently low free T4 with a totally variable TSH. Speaking of labs, a classic diagnostic trap you have to avoid is ordering total hormone levels instead of free T4. Why? Because total levels represent both the unbound hormone and the hormone stuck to transport proteins, like thyroxine-binding globulin. Things like pregnancy or taking oral contraceptives actually increase those binding globulins. That artificially skews the total T4 level, making it look totally normal or even high when the patient is actually hypothyroid. Bottom line, always order free levels so you know exactly what active hormone is actually available to the tissues. Okay, Section 4, Systemic Complications and Emergencies. Now we're escalating the stakes. What happens when this condition just goes completely unmanaged? Well, the systemic damage is pretty insidious when the cellular engine runs out of gas. Up in the brain, you get cognitive slowing and depression, which tragically gets misattributed to just getting older in a lot of patients. In the blood, decreased erythropoietin drive leads to macrocytic or normocytic anemia. In the heart, reduced LDL receptor activity causes aggressive dyslipidemia and atherosclerosis, not to mention the risk of pericardial effusion. And reproductively, it wreaks absolute havoc, leading to infertility and a significantly higher risk of pregnancy loss. And that brings us to the ultimate medical emergency, the end stage of decompensated hypothyroidism. Myxedema Coma. You absolutely must recognize the classic triad here: hypothermia, bradycardia, and coma. The mortality rate is massive. The action plan requires immediate ICU admission. But listen closely, because this is a critical ward pearl. You must give IV hydrocortisone first. You have to cover for potential coexistent adrenal insufficiency before you ever push IV thyroid hormone. If you suddenly rev up that metabolic engine with levothyroxine while the patient has depleted cortisol, you'll throw them straight into a fatal adrenal crisis. Do not forget that step.
Let's wrap up with Section 5, Board Prep and Clinical Pearls.
Let's test your active recall with a classic high-yield board scenario that always trips people up. Imagine a patient with a known pituitary tumor who has classic hypothyroid symptoms. You check their labs, and the TSH comes back totally normal at 1.2, but the free T4 is distinctly low. How would you interpret a normal TSH paired with a distinctly low free T4 in a highly symptomatic patient?
The answer is central hypothyroidism. This goes right back to that TSH trap we talked about earlier. The diseased pituitary is completely blind to the low T4. So even though the body is literally starving for thyroid hormone, the broken command center fails to raise the TSH in response. Never rely on TSH alone if your clinical suspicion points to central pituitary disease.
Let's try one more common scenario. Say you have an asymptomatic 45-year-old woman with a mildly elevated TSH of 8 on a routine screening. Her free T4 is completely normal. What's your next step in management for this classic subclinical presentation? Do you just start levothyroxine right away? Absolutely not. You need to hold off on medication and just recheck that TSH in 6 to 12 weeks. When you have an asymptomatic patient with a mildly elevated TSH, specifically under 10, and a normal free T4, you have to rule out transient lab anomalies before you commit someone to a lifetime of hormone replacement therapy. Finally, arm yourself with these practical counseling pearls, which are especially true in Indian clinical practice, where Hashimoto's has actually become the leading cause of hypothyroidism in iodine-sufficient urban areas. You have to actively counsel your patients to fiercely protect their medication's bioavailability. Remind them, every time, to take levothyroxine on an empty stomach about 30 to 60 minutes before breakfast. And this is huge. They must separate it from calcium and iron supplements by at least 4 hours, or those minerals will completely block its absorption. Also, warn them not to casually switch pill brands without getting their TSH rechecked 6 to 8 weeks later. We've covered a ton of ground today. We traced the path from the microscopic cellular machinery right through complex diagnostics and finally to bedside management. It really shows just how totally dependent the entire human body is on this one tiny vital engine in the neck. Remember, TSH screens, free T4 confirms. I want to leave you with this final thought to ponder as you see patients on the wards. If literally every cell in the human body requires this hormone to function and generate energy, how many subtle systemic failures, how much cognitive slowing, fatigue, and heart disease are we missing right now simply because we're blaming it on aging? Keep your differential broad, trust your diagnostic algorithms, and always, always check the engine.